Hello everyone, good afternoon. Neil Dion, hip and knee surgeon at Concord Orthopaedics, coming to you live from my home office here. Bit of an unusual time for everybody. I'm here today to answer general questions about Concord Orthopaedics and questions specifically about hip and knee replacement. So, going to start by just going over some general information. Want everyone to know that our office is still open. We are an essential business, and so we are operating with some significant differences, as you might guess. We're transitioning as much as we can, as much as we safely can, to telemedicine for our patients. And we've had a lot of success with that. We've been off to a great start with that. But certainly the office is still open and available for patients who need to come in to be seen. We are screening appropriately in association with the CDC guidelines. So there will be some differences for patients coming in, but we're here and available for you if you need us. Our acute injury clinic, our walk-in clinic, is still open as well. We're running that Monday through Friday from 9 to 4 currently. And again, with the appropriate screening. Specifically for what I do with hip and knee replacement, we've done a lot of telemedicine for post-op patients, for pre-op patients, and even for patients who are brand new to me in some cases. And so you can certainly call our office 603-224-3368 to set up any visits that might be needed. It's been a different time in our office for sure. I haven't done a hip or knee replacement in close to a month now, as we've been preserving protective equipment for other departments in the hospital that obviously need it more right now. The only hip replacements that are really being done currently are for certain types of hip fractures, which we are still doing for patients. And all right. So I was given some talking points today by our extraordinary marketing director, Matt Johnson. I'm going to look through some of these here. So benefits of telemedicine. There are some real benefits. We're fortunate. We draw from a large community to Concord Orthopaedics, and so we have patients who come a long ways away for their follow-up visits for surgery. And we've learned over time that that's not always necessary, and so we can take great care of patients after their surgery with telemedicine at times. And so for someone who's not initially quite as mobile as they want to be, sparing them the long drive down the highway is something that I think we'll continue to provide moving forward after this passes. Got a couple of questions coming in here. Let's take a look. How do you know if it's a hip problem or bursitis or muscle or tendon issues? That's a great question. The classic place for true hip pain, something that's coming from the ball and socket joint to hurt, is typically described as groin pain, or pain that someone's feeling in the front. Bursitis is far more often felt as pain that's on the side of the hip. And so for the vast majority of patients, that will play out to be true. As people get more severe arthritis, they truly can have pain 360 degrees around the hip. But the classic true hip pain that we see with arthritis is most often groin pain, whereas bursitis pain is on the side of the hip, over the greater trochanter, that bump that we can all feel on the side of our hip. And so while not everybody follows that pattern, that holds true a great majority of the time. Let's see another question here from Dr. Levy. Is it possible to play golf or ski after total hip or knee? The answer to both those questions is yes. I've been fortunate to take care of a number of skiers, ski instructors, ski patrol, and thus far patients are able to get back to it. Now, for more of the weekend warrior or less experienced skiers, it becomes a risk-reward type decision that people make, and so it's true that you can ski afterwards. The consequences of skiing are always real, and that doesn't change after joint replacement, and in fact the consequences can be even higher if you do have a fall or an issue afterwards. And so in my experience, most of the patients who skied quite a bit before their surgery are able to get back to it. Those who didn't ski regularly and weren't heavily invested in skiing often choose not to go back to it, not because they feel as though they can't, more so because they want to protect what they like, which is their new hip or knee that feels much better afterwards. Golfing, almost universally, patients are able to get back to golfing after hip or knee replacement. A lot of times they're chipping and putting a few weeks later, hitting balls maybe 6 weeks or so after surgery, and then playing around closer to 7-8 weeks. A couple more surgeries. When do I think surgeries will happen? That's a great question. We're here and available and ready, and we've been fortunate in this state thus far as the fact that the numbers have remained relatively low. And so as we get to the other side of the peak, hopefully, and we can start safely offering surgeries in conjunction with Concord Hospital and our surgery center, we're looking to get back to it as soon as we safely can for patients. And it probably won't be the same for all patients. I think there's a lot of benefits to having a hip or knee replacement in a surgery center rather than a hospital anyways. I think that's particularly true right now, where it's a much smaller number of people who are in that building on a given day. And so I'm optimistic, though certainly there's a lot of work to be done and information to gain, but I'm optimistic that we'll be able to offer joint replacements next month to certain patients at least. Does a knee prosthesis have limits on range of motion, both flexion and extension? So that's a great question. By and large, a normal, healthy knee has a range of motion from approximately 0 degrees, so full extension. It can come straight and bends to somewhere in the neighborhood of 140 degrees, and that's variable. As patients get arthritis, they often, though not always, get limitations in their range of motion, and so a lot of times patients, before they have a knee replacement, don't come all the way straight. Maybe they're missing the final 5 degrees or so, and they bend to somewhere in the neighborhood of 120 degrees. The vast majority of patients who have a knee replacement these days are able to get full extension, and so that's 0. And then in terms of flexion, it's great, and I think the majority of patients get to 120 degrees. A lot of the classic studies tell us that once you can get to 105 degrees, you're able to do most of the normal things in daily life that we want to do, be it going up and down stairs normally, tying shoes and whatnot. And it's increased over time. I think, probably 20 years ago now, there was a big article that showed an average range of motion after joint replacement of 107 degrees. And the truth is we're better than that now. Knee designs have improved. Surgical techniques have improved. But that's not true for everybody. And the biggest predictor of post-operative motion is what your motion was before you had the surgery. And so people who are exceptionally stiff don't necessarily get all of that motion back. They typically improve to some degree, but it's variable. What they do generally get is dramatic improvement in their pain, and that's a great reason to consider knee replacement for appropriate patients. Question about knee injections. Yes, absolutely, and that's probably a large number of the patients who I've been seeing in the office recently, patients who have significant pain that limits their mobility. For whatever reason, they're not looking at having a knee replacement in the near future, and so obviously we can't do knee injections over telemedicine, and so a lot of those patients are choosing to make appointments and come into the office, and we're happy to see them in a safe way. Again, their patients have varying degrees of risk being outside the house right now, and so, if a patient is 85 years old and has some pre-existing lung problems, perhaps the risk-benefit for them is not worth coming into the office right now. Perhaps it's wiser for them to wait a few weeks until things calm down and then come in for injections. But for the healthy 60-year-old patient who's having trouble working, maybe they're an essential worker too, and absolutely, it can make sense for them to come in and get those injections. And so we're in the office, and we're happy to do those right now. Our office in Concord is open, and our office in Derry is open several days per week as well. Question here, common symptoms of hip arthritis. And so the classic symptom is groin pain. People describe pain in the front of their hip, and that's the classic symptom. But some people notice stiffness even more than pain, and so patients will have trouble putting their socks on. Patients will have trouble putting their shoes on or tying their shoes. Those are classic symptoms of hip arthritis. Patients will notice that they're limping and having difficulty walking longer distances, or difficulty even sleeping at times would be the most common symptoms of hip arthritis. Continuing on. Hoping I can get back to getting my next shot into my back. So yes, spine injections are being done in our office as well by some of my colleagues. If you call our office, that is certainly the type of appointment that you can set up currently. How do we diagnose hip or knee issues via telecommunications? So that's a great question also. And the answer is we do it in a lot of the ways that we typically do. However, we don't have a formal physical exam that we can do, at least to the same degree that we would do in the office. And so, if you have a telecommunication appointment with me, usually they're done video and audio. So I'll ask you questions. Do you have groin pain? Can you point to where it hurts? What type of activities are causing this pain? We'll look for some of those key indicators that tend to follow the pattern of hip arthritis. Sometimes patients have had x-rays in the past. Those can be extremely helpful. A lot of my patients honestly come in already with a known history of arthritis of their hip or knee and are looking for treatments. Those are easier visits, but there are some maneuvers that we can do with telemedicine as well in terms of physical exam. And so I can watch patients walk. They can set up their cell phone or iPad and walk across the room for me. I can have them replicate some of the maneuvers that I would typically do on exam to see if they have stiffness and some of the other signs that we see with hip and knee arthritis. Can have them point to where it hurts, and so yes, I wouldn't say that telemedicine is as effective as having an appointment in the office, but it's surprised me how useful it's been in terms of getting patients treatments that can help reduce their symptoms. Why do people need to have x-rays to properly diagnose knee and hip issues? And so the vast majority of my practice is aimed at treating hip and knee arthritis, and so the number one testing modality to identify that is loss of joint space on a radiograph. And so patients out there who've been in the office with me, we typically try to look at your x-rays together. And what we see with x-rays of hip or knee are loss of joint space, and cartilage doesn't show up on x-rays. However, the absence of the cartilage shows up as loss of that space, with areas of bone rubbing on bone in severe cases. And so x-rays absolutely our number one modality for identifying hip and knee arthritis, confirming. Just looking through some of the other questions here. if you're scheduled for a pre-op phone interview early May, will that still occur? I'd say it's probably worth reaching out to our office to have a discussion, and again, depending on the situation, it could be different for different patients. However, as of right now, we're optimistic that that will still occur for early May. Continuing on, is moving around better for arthritis or staying immobile? So moderate activity has been proven to be helpful for patients with arthritis. One of the American Academy of Orthopaedic Surgeons treatments, non-operative treatments for arthritis is physical therapy and moderate exercise. And so certain types of exercise are counterproductive. High impact exercises, so distance running is not a great exercise for patients with hip or knee arthritis. However, various forms of light stretching and even some weight resisting exercises, as well as swimming, cycling, elliptical use are all generally helpful for arthritic pain. Of course, situations can vary for different patients, but in general, motion is better for patients with arthritis. Question here. I had my hip replaced almost 2 years ago with great success. I do have leg length discrepancy. This causes a lot of pain. I have had lifts made. They help a little. Any suggestions? It's tough to comment on specific cases without having looked at x-rays or examined patients, at least by telemedicine. If you'd like to make an appointment to the person who sent that question, I'd be happy to look everything over with you. To talk about leg length discrepancy in general, it is a known risk factor of hip replacement. It's uncommon and becoming less common, I would say, that the symptomatic or leg length discrepancy that patients notice and have symptoms from is generally in the neighborhood of 1 to 2% in modern studies. And again, though, just because you have a subtle discrepancy. So a lot of patients have discrepancies if we're going to look at millimeters, and in general patients aren't able to appreciate those or notice them. And so there are a lot of reasons why patients can have pain with a hip replacement, not necessarily from a leg length discrepancy, especially if it's very small. And so while it is difficult to comment on specific cases, again, I'd be happy to take a look if you'd like to call and make an appointment. Great news to hear that we're starting to reschedule appointments for shots. Yes, we're very happy with that as well. We think that's something that we're able to offer to our community safely at this time, and patients have been happy with that. Saw a question a bit back asking if there are any supplements to take for hip or knee arthritis. And in general, I would say the answer to that is no. I think a well-balanced diet moderate exercise have been shown to be helpful, but in terms of specific pills to help patients with arthritic pain, in general, the answer to that is no. None of those have been proven to be helpful. When family members ask about things like glucosamine chondroitin, and I typically tell them all I can tell you for sure is that those things cost money, and furthermore, a lot of those supplements aren't evaluated by the FDA in the same way that medications are, and so I do not recommend those to patients typically. Every once in a while you'll find a patient who swears by them and feels that they help quite a bit. For patients where that's true, I think it's fine for them to continue taking them, but it's not something that I generally recommend patients go out and try. Looking through here again. When I walk, pain on side of hip and groin, and suddenly and hurts bad, stops me in my tracks, wish I knew why. So again, typically pain on the side of the hip is coming from bursitis, but that's variable, and it would depend on what the imaging shows in terms of the treatments that would be recommended. Continue to look through here. Great. Okay. I brought some props along in case we had a lull in the conversation to try to show some of the implants. And again, these are actually real implants. What I'll show They're not necessarily the ones that I typically use in a given day, but the structure is similar amongst different implants. And so a hip replacement typically has 4 parts. There's 2 parts on the socket side and 2 parts on the femur or the thigh bone side. And so on the socket side, we'll typically have a hemisphere such as this, which is usually made of some type of titanium alloy. Okay, and this will go into the pelvis into a very tight fit. And you can see that there actually is a metal surface on the back of this that is rough and irregular. And so there are small pores that your bone will grow into over time to form a union with this. And you can see that there are screw holes. Sometimes we use those as a supplement to hold this in place as the bone grows into these small pores, though it's not always necessary. Into this, we would fit a plastic liner, thin liner that has the same shape as this, and will lock into this mechanism here. And that will mate with the femoral component. And so this is a type of femoral component that's used at times. And again, you can see a irregular surface here, and pores measured on the in terms of micrometers. And again, your bone will grow into this over time, and so we machine the bone to accept this with a very tight fit, and put that in place. And then on top of that, we will put a ceramic or metal ball, and so this will recreate the ball and socket joint. You can see there, again, there'll just be a plastic liner inside the socket here that I don't have with me. And additionally, can show you a knee replacement here. And so the clear acrylic here is representative of the bone, and this would be a metal femoral component. You can see a side view there. The white rubber band looking things would be to replicate the ligaments, the medial and lateral collateral ligaments that patients keep when they have a joint replacement typically. And so there's a metal femoral component, a metal tibial component, so this is the thigh bone, this is the shin bone, and then a plastic liner that goes in the middle. And so you can see an example of how this knee would articulate here. So a lot of patients notice afterwards that they'll tell me, my knee feels great, I just noticed that it clicks a lot. And so the reason it clicks is because you have metal brushing up against plastic, and that's kind of a normal thing that we see for patients who have had joints replaced. And so again, you can see simulating that range of motion here. Good. So again, to summarize, I want everyone to know that Concord Orthopaedics is open. We are available for you in the office or by telemedicine. We're using platforms including even things as easy as Google Duo and FaceTime. These are modalities that typically aren't allowed by the government for healthcare due to privacy concerns, but given the ease of use right now and the minimal setup that's required, healthcare providers across the country are being allowed to use these modalities because it allows us to bring care to our patients in a safe way right now with the ongoing pandemic. And so we're available for telemedicine throughout the week. The acute injury clinic is open from 9 to 4 p.m. Monday through Friday. Again, walk-ins are still welcome for urgent evaluations. Again, you will be screened as recommended by the CDC. So we are seeing patients both in the office, we are seeing patients by telemedicine, and we hope to be offering elective surgeries soon. Our urgent and emergent surgeries are ongoing. No one's being denied emergent surgeries at this point, nor do we anticipate that happening with the pandemic. But we hope to be back to doing elective hip and knee replacements, potentially as soon as May, if the pandemic heads in the direction that we all hope at this point. So it's been a challenging time for everyone. We've been so impressed by the great staff that we're lucky to have at Concord Orthopaedics and our surgery center, as well as at Concord Hospital. They do excellent work. They've been brave, they've been caring and compassionate, and we all appreciate it. So thanks to everyone who's been watching today or who will watch later online. Hope to do this again in the near future, and feel free to reach out 603-224-3368 to make an appointment, or if you have any questions. Thank you. Take care.